Good afternoon. I'd like to welcome you to the session on imaging in radiotherapy. So, the ICRP in 2018 set up a task group to look into imaging in radiotherapy. The reason for this was that over the past a couple of decades, the techniques for providing radiotherapy treatment have really advanced so that it's now possible to mold the radiation field quite accurately to the shape of a tumor. But if you're going to utilize that facility, then you need to have your patient in the right position. And so over the last 20 years, the amount of imaging and the imaging techniques have gradually been developing. And so we know that in many places, not a lot of attention has been given to radiation protection. So the ICRP set up a task group to really provide guidance on this. And so this session is really sort of based around our sort of work and related aspects. We'll start off, Yumi Lee has been reviewing the posters that have been submitted, and she'll give a summary of the work that's been done.
Good afternoon. My name is Yumi Lee from Yonsei University, Republic of Korea. I am honored to serve as your reporter for session 13 of the 7th International Symposium on the System of Radiological Protection. This afternoon, it's my great pleasure to summarize the contribution poster and pre-recorded video on imaging in radiotherapy. As we have examined the breadth of research presented, it is impressive that our symposium has showcased 249 posters and 83 pre-recorded video, marking the highest contribution in our ICRP symposium history. A significant portion of this contribution, 67%, was from Asia and the Pacific, underscoring the region's active engagement in our field. Throughout this symposium, we have had the opportunity to engage with the diverse array of research across 18 main themes, presented through contribution poster and pre-recorded video. These themes are representative of our field, addressing critical aspects of radiological protection, innovative methodology, and emerging technologies. In our specific session on imaging in radiotherapy, we observed a notable advance and insight. In our specific sessions, one of the outstanding presentations was from the team from Loyola University, Chicago. They proposed a practical CBCT dose optimization method utilizing tools like 0.6 cc air, calibrated thermal ionization chamber. They assessed air, for various CBCT protocols and aim to reduce imaging doses by adjusting projection and frame exposure. Their research established the linear relationships between air, CBDI and weighted CBDI, allowing for dose optimization while maintaining clinically acceptable scan. They noted, however, that reducing projection over 50% could introduce considerable effect. This adaptable methodology for CBCT protocol optimization is a significant contribution to radiotherapy practice. Another highlight was the work of Shio Maite and his colleagues from Japan. They highlighted the benefit of stereotactic body radiotherapy for spinal metastasis, offering improved local control and pain relief over traditional method. Nevertheless, local failure remains a concern, affecting 10 to 28% of patients. The team aimed to predict local failure more accurately by analyzing 139 lesions and extracting radiomic and dosimic features from CT images and dose distribution. Incorporating radiomic, dosimic, and clinical features, their model achieved a notable accuracy, outperforming model based on clinical features alone. Due to the time limitation, I would like to briefly mention the author and title of the research in the session. A variety of topics have been addressed in our session. From Colombia, Christian David Trujillo Bastidas and his team examined the ITX Clear IT system and its impact on patient registration and verification accuracy. Ayang Lee from South Korea investigated the effect of deep learning-based denoising technique on reducing patient radiation doses. Additionally, Han Wei Tan from Singapore explored dosing strategies for fractionated radiotherapy in a cell culture model. Ji-won Sung, also South Korea, presented the optimal relative electron density assignment for adaptive treatment using 1.5 Tesla MR lineup. Dwi Sheng Supriyadi from Indonesia focused on optimization allowing thickness in patient position verification imaging, while Uriel Assembret from France discussed the radiological protection aspect of imaging in radiotherapy. Cha Wei-yu from Taiwan offered insight on optimization strategies for bladder side for treatment planning in prostate cancer patients. Manan Aleji for Saudi Arabia shared strategies for radiation dose reduction in SPECT-CT bone scan. Lastly, Arman Nishkan from Japan validated quantitative parameter derived from liver scanicality with significant implication for imaging in radiotherapy. In conclusion, the breadth and depth of research presentation in this session are more than just impressive. Thank you for attention.
So we will have our questions and comments after all the speakers. And I'm Dr. Makoto Hosono, co-chair of this session, together with Colin Martin. And Colin is our next speaker. I will introduce Colin. Colin is a distinguished scientist in the field of radiological protection in medicine. He has been vice chair of Committee 3 since 2017. He is the chair of two task groups, Task Group 108 and Task Group 116. And this Task Group 116 handles radiological protection aspects of imaging in radiotherapy. So Colin is the right person to discuss imaging in radiotherapy. So Colin, the floor is yours.
Thank you, Makoto. Yeah, well, I want to talk about a survey of image-guided radiation therapy, IGRT, practices around the globe. And my presentation will include something about image-guided radiation therapy, talk about this survey of imaging practices, talk about the use of images in planning and verification, I talk about the imaging modalities available, the frequency of imaging, the optimization of verification imaging, and also at the end say something about recording patient doses for cone beam CT. Now, conformal treatment fields are delivered from multiple directions to focus the therapeutic high dose on the tumor. And the linear accelerator continually reshapes the beam and changes the intensity as the gantry moves around the patient. So this enables the radiation field to be conformed more accurately to tumor shapes and allows doses to healthy tissues surrounding the tumor to be reduced. So these improvements in treatments really can only be realized if the patients are positioned precisely in the radiation fields as they've been planned. And in order to achieve this, you need to check using imaging. So imaging has become an important part of radiation therapy delivery. So if we look at image-guided radiation therapy, we image at the planning stage, producing the initial plan for the treatment. Then we have verification immediately before treatment delivery to adjust for positional uncertainty. And then later on, we might do more imaging to assess the response at a later stage. But it's the first two, imaging for planning and the imaging for verification, that we've been looking at. Now, a high-dose margin is left around the tumor to ensure that a treatment's effective and as many of the cells, cancer cells, are killed. So IGRT allows the size of the high-dose margin covering normal tissues to be reduced. And in this way, it may allow target doses to the tumor target to be raised if the doses to the critical organs can be reduced. But the imaging fields, they cover the area surrounding the tumor. So the irradiation of normal tissues increases the risk of inducing second cancers in these tissues. Now, ICRP set up the task group to consider the aspects of imaging, but we really could only find limited information or information on practices on the use of imaging from high-dose countries in the literature. Now, it was at the same time that the ICRP set up their mentorship program, and we received applications for positions linked to TG116 from countries around the world. And so, seeing the wide spread of countries, we used the opportunity to initiate a mini survey of imaging in radiotherapy in these countries. And this was to give us a snapshot in the range of practices that are used. So it's not a full global survey, but it gives us a snapshot. The technique used was SurveyMonkey, which the ICRP uses for surveys. So the mentees were given the opportunity to coordinate a survey of imaging practices in their countries. Then they established links with the radiotherapy centers in their countries and encouraged them to complete a questionnaire. And this survey had initially 143 radiotherapy centers registering, but in fact 100 completed the full questionnaire. The questionnaire itself was quite large, comprised 16 pages with 130 items, including about Linacs, KV, imaging equipment, and the frequency of imaging. And the data was in the data we got was really in 9 country or regional groups, which was sent to the mentees. And the data was ordered in Excel spreadsheets for ease of analysis. And then the mentees analyzed the data from the radiotherapy centers. But having the mentees in the country enabled us to sort out any anomalies in the data, because they could go back to the radiotherapy centers and discuss the results with them. So the TG members prepared a draft report. This was sent to the participants to review and then published as a paper in 2021. Well, we wanted to know so what was the best way of analysing this sort of data from a wide diversity of countries, and we decided that the use of what's called a Human Development Index was probably the most appropriate. This combines measures of life expectancy, education, literacy, and receipt of different levels of education, and per capita income. So in order to allow differences in practice to be viewed in relation to the level of development of the country, we use this HDI. So the values move towards 1. They sort of increase here as the level of development rises. So the results were ordered by the country HDI level. So this shows the results for treatment planning exposures. So they're ordered, if we go from left to right, in increasing HDI. And so you see the radiotherapy centres with the higher HDI numbers had more, or were able to use more facilities such as MRI. They were able to use data from PET-CT imaging, from SPECT-CT, and from ultrasound in planning the exposures. In the verification images, we found that IGRT is starting to be used really in major radiotherapy centres throughout the world, and centres in all the countries except the one with the lowest HDI used images for verification in between 75% and 100% of treatments. So a percentage of treatments for which centres use guidance is given in this. So we have the proportion of centres using image guidance on the vertical axis, and then the percentage of treatments that use it at the different centres in the horizontal axis. And so again, the numbers using it increase to some extent with the HDI level. Here we've got the HDI rising from left to right. So what imaging facilities are there? Well, there's linear accelerators, have KV imaging facilities. They have an X-ray, or most of them have an X-ray tube and image detector plate that can rotate around the patient and record planar or cone beam CT images. The MV, the therapy beam, can also be used with electronic portal imaging devices to produce images, but the contrast is poorer and the doses are higher. So this is not as good a form of imaging, but it may be all that's available on some Linacs. So imaging requires fields covering the area surrounding the tumour for position verification. So you have a larger field and normal tissues are irradiated, and there's an associated risk of second cancers being induced. Now, the techniques used for image guidance, we're showing the proportion of centres using the different techniques, and you see that KV cone beam CT is the main technique used for verification imaging. And again, it's the higher HDI countries that have more of these facilities. And countries with lower HDI values, they have fewer Linacs with KV imaging facilities. But you can use non-ionizing radiation imaging in verification. So some Linacs have magnetic resonance imaging available on, but obviously these are more expensive and predominantly in higher HDI countries. You can use optical surface guidance, which is used a lot in certain countries for monitoring the skin surface as a way of verifying position, or you can have ultrasound image guidance provided by real-time volumetric imaging. Now, if you look at the frequency of verification, this is for treatments of prostate and breast. The majority of the centres using image guidance imaged once per fraction. So that's every time that the radiation is carried out. But the higher income countries were the ones who predominantly did this. As we got to lower income countries, the availability of KV imaging equipment was less, and so you got quite a few centers maybe only imaging once per course of treatment, or perhaps once per week. And this shows similar data for the head and neck and lung treatments. And again, higher income countries image at every fraction, but the country with the lowest HDI had few linacs with KV imaging. So the radiotherapy centers image once per week or once per course of treatment in these in many of these centers. Now, the protocols used for imaging are often supplied by the vendor, or no, well, almost always supplied by the vendor. But the level of image quality required is adequate, but they haven't been really optimized in terms of radiological protection. So 90% of the radiotherapy centers use these vendor imaging protocols, especially in the lower HDI countries. And the other surveys have shown that protocols installed by equipment vendors are often not optimized for radiological protection. So again, the more optimization tended to be done by the higher income countries because they've got more staff with the expertise and more equipment. So fewer than 50% of the radiotherapy centers made adjustments to protocols for individual patients. So most were using a sort of standard field to image patients of all size and making no adjustments for the size of the patient. So if we look at radiation doses from imaging, we thought that, well, coming from the UK, that most people would be recording patient dose. But in fact, we soon found that that was not the case. About 50% of European radiotherapy centers recorded patient doses, but less than 10% of radiotherapy centers in other parts of the world recorded them. And so, and this wasn't only the low HDI countries, this was spread across all the many of the higher HDI countries in other parts of the world other than Europe. So that's the left-hand column, or the left-hand grouping here. We also looked at the QC on imaging dose and on image quality that was done. So most centers in higher income countries measure image quality during their QC tests, but many don't measure the dose quantities. And centers in the countries with lower HDIs often don't have tools to measure imaging doses. So there's quite a sort of gap to what you can really do with optimization if you if you don't know what the doses the patients are getting for imaging are in the first place. So in summary, radiation treatment fields can be conformed accurately to the shapes of tumors. Improvements in treatment delivery require accurate patient positioning. The imaging is needed for both planning and verification of patient setup. Radiation fields for imaging expose normal tissues surrounding the target. And a survey of imaging practices in radiotherapy has been conducted through our task group, using the mentees, and most radiotherapy centers use imaging for verification in 75 to 100% of treatments. Cone beam CT is the main technique used in high and middle income countries, and these countries frequently image at every fraction. So most centers use protocols supplied by the vendors with limited optimization, and fewer than 50% of radiotherapy centers record doses received by patients from imaging. So this has given us something of an idea of what is happening at the moment so that we can base our recommendations in our report on this. And so I'd like to acknowledge the contributions from the members of the task group and also the mentees in the various countries for TG117 who are involved in this survey. And thank you for your attention.
Thank you very much, Colin. You have clearly demonstrated the overview of the results of the survey on image-guided radiation therapy across the globe. So our Colin will be chairing the next talk. Yeah.
Thank you very much. So I want to introduce Thomas Cron, who is a sort of principal research physicist at Peter MacCallum Cancer Centre. So he's a regular consultant for the IEA. He's written hundreds of papers on these sort of topics, and has been invaluable in supporting the work that we've been doing and keeping us right, because I'm a diagnostic physicist and we need radiotherapy physicists with imaging experience such as Thomas.
Thank you very much, Colin. Good afternoon, dear colleagues, dear friends. I see some familiar faces in the audience, so I don't need to talk too much about radiotherapy, and I can sort of focus more on the ignorance which I personally brought to the field when starting there, with an interest in imaging, and particularly a very clear appreciation that imaging is good for us, but not really a clear appreciation about the radiation doses. And I would like to take you on a journey now, taking some of the things Colin has said about the whole world, and try to illustrate these in our institution. I've chosen the term fit for purpose rather than optimization, because that gives me an opportunity to talk to our clinicians and engage in optimization and dose reduction where possible, by still saying this is good for what you want to do. And that's really what this all is about. This is the center where I'm coming from, and I'm aware that we are in a privileged position, operating on 5 campuses in a very large organization with 16 linear accelerators. And one interesting point already is we did these tests about linear accelerators on 15 identical linear accelerator, nominally identical linear accelerators, and they're all within 10% of the radiation dose in imaging. So there is potentially not quite as much work out there to do, because the standardization of the manufacturers is actually not too bad overall. It gives me also an opportunity to share with you my conflicts of interest. There's a lot of talk about ethics and transparency. We have research collaborations with Varian, Vision RT and Reflection, and I should sort of point out that Vision RT is an optical surface guidance company. We have now installed 10 of these systems, but I'm not going to talk about it. And Reflection is actually a PET image guidance company, and we don't have one of their systems yet, but we are obviously very interested in that. This is what a radiotherapy physicist sees there, and they see radiotherapy. We are giving doses of several gray, and then all the imaging is in the daily background area. But this paper by Jun Deng really sort of opened my mind about why it is still important to look at doses in imaging, because the dose distributions are so different. This is a prostate radiotherapy treatment, everything focused in the center with megavoltage radiation, and this is the cone beam CT dose. And obviously the cone beam CT dose looks completely different with the high dose regions outside, way outside of the area, and some areas actually, like the gonads in this case, get more dose from the imaging than they do get from the radiotherapy. So I'd like in the next 10-12 minutes introduce a bit more of the role of imaging in radiotherapy and explore then why this is not negligible. I would like to show you 2 main examples, one from imaging for planning and one for image guidance, where we have taken some steps to try and optimize the dose distributions. This is more or less the same slide Colin showed you in a much nicer and more colorful way there. This is the patient pathway. And I always think, as a physicist, it is quite important to try and put yourself into the shoes of the patient, because that's also what the clinicians see. That's what every person in the hospital sees. They see their patient pathway. And you can see here how many imaging instances we are seeing here. And these are just imaging which are specifically taken for the purpose of radiotherapy. You can see also that most of these are CT, and CT is great for radiotherapy because it gives us those calculation opportunities, and it is without any distortion. There are the two particular areas which Colin has already shown. One in terms of the imaging for planning, where imaging is frequently used, and then imaging for the image guidance as such, which sometimes identifies problems which only can be adjusted by replanning, and that is really something which finds itself now into the way into adaptive radiotherapy. I'd like to quickly take you to the area of 4D CT because normal CTs is something we all are used to. Diagnostic physicists often use 4D CT more as a cardiac-gated procedure, but we in radiotherapy are mostly interested in breathing-gated procedures, and it's basically taking more or less at the same position 10 CTs in different phases of the breathing cycle. This is done a bit more elegantly by using a helical scan, but it's more or less taking 10 scans at different phases of the breathing cycle, and you can see here what you can see in a coronal and sagittal image there. Clearly see that the tumor in this case moves. How do we use this? Well, in radiotherapy we would like to treat this lesion. And we should not need to actually think, where is that lesion at any point in time? So we would like to treat the area where always the tumor may go. And that is what we call the maximum intensity projection in this case. And that basically just maps wherever the tumor goes and marks that. So this is now our target volume. So if we now use that for treatment, there's no problem, because we always will hit a spot where the tumor actually is. There are other means of managing motion, like gating, breath hold, and so on, but I don't want to go into these. This is then what we would call an internal target volume, and which is quite useful. But as I mentioned, it is basically 10 CT scans at different phases of the breathing cycle, and you can see that here as well, again, which at least to start with, when this was introduced in the 2010 or so, some manufacturer basically just cranked the dose up to 10 times, so each scan would have the same signal to noise. That is obviously not something which is a good idea, and when we introduced 4D CT, we did an audit of all our procedures, and this is sort of shown here with the CTDI and DLP. It is shown something very common, well known to diagnostic people, and I would like to draw your attention to a couple of things. The one is that for children we can actually reduce the dose, and that is good, and we had to adjust these protocols because they were not available by the vendor. And it is also that the imaging volumes in radiotherapy are not identical to the imaging volumes in diagnostics, because we typically extend the volume a bit further, so we can model a non-coplanar image beam angles and guide the dose calculation. The results showed that in our hands, at least, we could manage with twice the dose on 4D CTs than conventional imaging as such. And that basically provides us with this sort of information, which is obviously tremendously useful for imaging. And it did actually show in a number of studies that the better target definition allows us to reduce the margins because the uncertainty is smaller. And that actually can, in some circumstances, like we published in a bladder cancer trial, can reduce the integral dose to the patient and therefore maybe the secondary cancer risk. However, that can only be done if we can actually localize this thing then again in treatment. And if you look at a modern treatment unit, which Colin has already shown you, then more than half of the additional features around it are related to imaging. All the yellow boxes here show stuff which is bolted onto the treatment unit. after the event in order to facilitate imaging. And as I rotate the gantry around the patient, I can also take up to 600 or 800 projections, KV images, and put them together and can reconstruct a cone beam CT image. And that is really a powerful tool, because it means that the imaging done in treatment planning and the imaging done in treatment delivery has the same quality, the same contrast and grayscale values, which makes the use of reference images much easier as such. But as I've shown you here already, the dose distribution is obviously quite different as such. We can, and we do, use Monte Carlo calculations to actually calculate the dose. As such, this is not something which is commercially introduced into any treatment planning systems. And one of the reasons which really got me worried about imaging in radiotherapy is that vendors do not provide any dose optimization tools. There's no auto-MA in cone beam CT, and the dose calculations in planning do not take imaging into consideration. And the people in treatment planning would say, yeah, that's perfectly fine. That's the combined image. And one of our PhD students, Hassan, has done a study with 10 lung cancer patients. And you can see here the dose volume histogram for the target. And you can see that the imaging in a typical treatment in these patients, where we took the images which were actually taken there, increases the dose only really absolutely marginally. That is used by manufacturers to say, oh, well, that's really just chicken feed in this context. But if you present a clinician with that, with a spinal cord, and have a retreatment, head and neck retreatment scenario where the cord has already been treated to tolerance, and the additional 3% of dose could really make the difference between paralysis or not, then people start getting interested in that. And we do use these Monte Carlo calculations in specific cases to actually calculate dose for individual patients. A couple of other things we've introduced over the years. One is just the collimation for cone beam CT. Nothing works automatically in terms of dose reduction in a radiotherapy scenario. And for the older cone beam CT systems, we introduced an additional copper filter, which is relatively easy to do. You just have to assemble the bow tie filter and put a bit of copper in there. And that actually makes sense, because the imaging tools are used for planar imaging and for cone beam CT at the same time. So the manufacturers really have sort of tried to do the best for both cases, but since we virtually only use cone beam CT, the optimization is really needed to be for that. And we did that also for the protocols as such. These are the manufacturer settings which we used initially, and these are the different imaging types there. You can see they are using different KV, different MA, and we measured the in-air dose there. And then use the 5-step optimization approach, and there's really no rocket science whatsoever. We measured the dose. We then took an anthropomorphic phantom and took up 120 images all together, cone beam CTs with different MA and KV combinations as such. But then we actually got the users, the radiation therapists, in and asked them, what do you think of that image? Do you think that image is fit for purpose? Can you position the patient appropriately based on that? And I think that is really the important aspect, to ask the user if the images are fit for purpose, and then we validated them in a more quantitative fashion. And another important thing, monitored the performance then in their first 30 patients. And this is basically what you can see there, the dose reduction factor without losing their fit for purpose is of the order of roughly about 2 in these cases, which I think will give our patients a bit of benefit. And you can see here some examples that the optimized protocols are not necessarily better. You can see that here, this image is clearly noisier, but it still allows us to do what we want to do in terms of bone matching or carina matching in this case. So in summary, modern radiotherapy relies on high-quality imaging during planning and treatment. CT is the golden poster child for radiotherapy as such, and probably will stay that for times to come because of the high spatial fidelity we have there. Dose optimization is typically not part of the radiotherapy imaging equipment design, but there is increasing awareness about the imaging because of the frequency, the ease of integrating images into treatment protocols, and we have now optimization tools emerging, and we are really not the only ones doing work in this area. There's a whole lot of different groups. The AAPM task group reports, Europeans, there's a UK effort to use dose reference levels, which we hope to extend into the 4D-CT and environment, and obviously there is the ICRP working group, which you have heard already. And I would like to finish here. Happy to answer questions, and would like to thank in particular Colin for taking me on this journey.
Well, thank you, Thomas. We'll take questions at the end. So we were left with a situation for optimization. So we need to know what the doses are. So our next question was, what do we do? And I want to introduce Mario Dukalic from Sir Charles Gardner Hospital in Perth, who's one of the mentees that we've taken on for Task Group 116. And he's been very sort of instrumental in sort of managing the collation of the dosimetry data that we've been collecting in a second part of our project, which he will describe now. Mario.
Thank you, Colin, for your kind words and your introduction. Ladies and gentlemen, welcome. Good afternoon. And welcome to my presentation of development of a methodology for measurement of dose for kV-CBCT in radiotherapy. On this picture, you can see a linear accelerator and schematically a patient having a head kV-CBCT image acquisition. As Colin mentioned in the first talk, our international survey showed that kV-CBCT is the most commonly and most frequently used imaging modality in image-guided radiotherapy. During the long patient journey of a radiotherapy patient, it can happen that a patient can have up to 30 kV-CBCT acquisitions during their treatment journey, which has the potential to have a high cumulative organ dose. And therefore, there should be a need for dose optimization in kV-CBCT. But as you all are aware of it, it's a fine balancing act. Because on one hand, you want to have good image quality, but that requires high radiation dose. But you don't want it to lower the factors too much because you don't want to have poor image quality. So the question is, what is the best tool, or how do we actually measure kV-CBCT imaging doses for dose optimization? Traditionally, the computer tomography dose index, CTDI, has been used, and it's still being used. It's a standardized method to compare CT beam output with the CT phantom and a 100 millimeter ionization chamber, and this is predominantly used in conventional fan beam CT. On the picture in the center, you can see the setup. So you place the CT phantom in the isocenter and you use the 100 millimeter chamber for taking the radiation measurements. You basically take a measurement in the center of the phantom and in the 4 peripheral positions of the phantom. And the weighted CTDI is essentially 1/3 of the central dose plus 2/3 of the average peripheral doses. The problem is that the CTDI formalism was made for narrow fan beam CT, but not for broad cone beam CT. And the problem is that in cone beam CT, you have way more scatter in the broad beam, and also the 100 millimeter chamber does not necessarily pick up the entire radiation. So how about we just ignore the fact and we're using the traditional method in a KV CBCT setup? The way it would look like is using this traditional CT phantom with a 100 millimeter chamber, but how about also using a pharma type chamber? So the task group TG116, with the help of Abdullah, performed some Monte Carlo simulation to see what the differences would be whether using a pharma or a 100 millimeter chamber. On the graph, you can see the cumulative dose, the CTDI normalized, in blue for the pharma chamber and in red for the 100 millimeter chamber. And you can see for the narrow fan beams, the difference is quite large. Once we go into the broad cone beam territory, so if we go beyond 100 millimeter beam width, you can see that the difference is getting smaller, which suggests that you could potentially use those chambers interchangeably. We also conducted, or the TG116 conducted another survey within the Mentee network to figure out what equipment is actually accessible in various radiotherapy centers in the world. And the results showed that actually the traditional equipment, which is the CT phantom and the 100 millimeter chamber, are not necessarily available. However, the survey showed us that radiotherapy centers tend to have pharma chambers and solid water phantoms. So the task group, suggested an alternative slab phantom setup. And on the picture on the right-hand side, you can see how the setup could look. It's basically stacking the slabs of solid water phantoms in a 30 by 30 by 30 cubic centimeter setup in a slab. But we need to bear in mind that the CT phantom is standardized and it's always made of acrylic PMMA. Solid water, there are different vendors, and the compositions of those phantoms could be different. I've shown you a few pictures, some examples. For example, the white PTW solid water phantom, the blue one from Sun Nuclear Corporation, and classic PMMA. So with the alternative slab phantom setup, we would just use the same methodology as the traditional CTDI. So you place this phantom in the isocenter, and you take a measurement with the pharma chamber in the center and the 4 peripheral positions. And the weighted dose index is similarly defined by 1/3 of the central dose plus 2/3 of the average of the peripheral doses. What we would like to do with the data is, we would like to see the differences at same conditions between the CT phantom and the slab phantom. The goal is to have a standardized and, more importantly, an accessible method to measure KV CBCT dose quantities that can be used as a comparison tool between radiotherapy centers and different protocols by using the weighted dose index. Thanks to our incredible Mentee network in our task group, which started with 7 mentees back in 2020 and has grown to over 22 mentees as of today, the task group developed a standardized spreadsheet and a standardized work instruction that was distributed to all the mentees in the network. And essentially, whichever setup was available in the mentee's home center we've asked to conduct, if possible, all three setups. The first one is the 100mm plus CT phantom combination, then the pharma chamber plus CT, and the alternative SLAP phantom plus the pharma chamber combination. And we asked them to conduct those measurements on the head, thorax, and pelvis protocol on their KV-CBCT imaging system. On this map, you can see all the participating countries in this survey. In orange, you can see the centers who were provided at the time of when I was writing those slides, who provided dose measurements data and equipment information, and the yellow countries show countries who provided equipment information. And it's good to see that we have data from all continents in this world. This pie chart shows the distribution of the three various phantom setups, and they're evenly distributed. On this pie chart, you can see that the mentees were using, or we received data from 5 different SLAP phantom vendors. And it seems to be that the majority of centers had access to the PTW white solid water phantom. Now I would like to show you the results. And on this graph, I would like to compare the CT plus pharma combination with the CT plus 100mm combination for head protocols. This is to see whether our results match with the Monte Carlo simulation I mentioned earlier. So on this graph, we've plotted the weighted dose index normalized, so it's milligray per MAS. And in blue, you can see the pharma chamber results, and in orange, the 100mm chamber results. And apart from a couple of exceptions, the results seem to be very similar, which is in accordance with the Monte Carlo simulation. Similarly, I'm going to show you the results for the pelvis protocol. And again, apart from one exception, the results between pharma plus CT phantom and 100mm plus CT phantom seem to match, which is good if you think about doing it on a large scale. If centers don't have access to the 100mm chamber, they could use the pharma chamber. Now I would like to show you the results where we compare the traditional CT phantom with the alternative SLAP phantom. But on this slide, I'm going to focus on the PTW phantom because that was the most commonly used phantom, and I also want to exclude the uncertainty that different SLAP phantom manufacturers have different compositions of the phantom. So on this graph, in blue, you see the CT results, and in orange, the SLAP phantom results. I plotted again the weighted dose index milligray per MAS. And I've shown, so these were data points where the centers were able to provide a like-for-like comparison. So exactly the same conditions between CT and the SLAP phantom for pelvis and thorax protocols, and also shown that we also had data for Varian Linux and Elekta Linux, which are the two major companies in Linux. And it's good to see that the results seem to be very similar. So now I've shown, to summarize, the mean difference for the PTW SLAP phantom versus the CT phantom ranges between 3 and 11%. And those numbers show where I combined all the phantoms and all the vendors together. And the mean difference between CT phantom and the SLAP phantom is between 1 and 11%. However, we've noticed there have been a few outliers, and the difference can be up to 24%. And we are in the moment figuring out and investigating. We have a few assumptions what the uncertainties are. So to close the loop and go back to image optimization and why we are using this tool, I want to show you the results for the pelvis protocol and the traditional CT plus 100 millimeter method. But I would like to point out that I've plotted now the absolute weighted dose index, so milligray instead of milligray per MAS. So as you can see on the lower end, some centers can produce pelvis protocols as low as 5 milligray weighted dose index, and some centers go up to as 40, almost 40 milligray weighted dose index. So this is a factor of 8-fold. And why is this important? Because at the lower end, you could ask the questions, do those protocols have inferior image quality? We don't know. And on the upper end of the spectrum, you could ask a question, do those pelvis protocols provide too much imaging dose? We don't know. And that's why it's good to have a standardized dosimetry tool that can be then used to compare your results with other centers and trigger a formal image dose optimization. To conclude the work, the international sample shows that there's room for optimization for adjusting kV-CBCT radiation dose across all imaging protocols. The CT plus pharma and the CT plus 100 millimeter chamber combination show similar results. And our first results indicate that the SLAP phantom is a viable and, more importantly, accessible alternative to track kV-CBCT imaging doses for dose optimization. In the future, we would like to perform more Monte Carlo simulation and hopefully take more measurements from our incredible Menti network in order to get an even bigger sample size and in order to draw more conclusive conclusion. I would like to thank ICRP for giving me and my Menti colleagues the amazing opportunity to be part of a mentorship program and provide a small contribution to the work of the TG116. And yes, I would like to thank the task group and my fellow mentees, and also Colin, Tim, Sebastian, Abdullah, from whom I've learned a lot, and my mentor, Thomas Cron, for the guidance over the years. And of course, I would like to thank my home department in Perth, because they allowed me to spend some time to do some research and do a small contribution to this project. Thank you very much for your attention.
I will introduce Dr. Shinichiro Mori. Dr. Mori is an expert of medical physics in radiation oncology, especially carbon therapy, because Mori is working for QST, where carbon therapy HIMARC is leading the world in constructing standard of carbon therapy. Mori has a great contribution to building the standard and the accumulating the findings regarding the medical physics in carbon therapy. So, Shinichiro, let's get started.
Thank you for introducing for me. So, and also thank you for the chairman for giving a very good opportunity for the ICRT. So today I'm here to give our clinical implementation image processing techniques into the particle beam therapies. And I would like to introduce the number of the treated patients in QSC hospital. We have two fixed beam port treatment rooms and one rotating gantry systems. And we started scan carbon ion beam treatment in 2011, and the number of the patients were increased every year. Now about 900 patients were treated every year. Approximately 40% patients were treated by gating irradiations. And compared to the proton particle beam, and particle beams is strongly affected by the variation in the radial path length in the beam directions. And from right image, you can see that the potential variation of 1 centimeter in the water causes 3% doses in differences in photon beams, but 90% in particle beams at the distal 4 of positions. The magnitude of these dose degradation is significantly larger in particle beam therapy than in photon beam therapies. And the difficulty is further emphasized within the lung region due to the high density difference between the relative solid tumor and low density tumor tissues, lung tissues. And one major problem in particle beam therapy is the range uncertainties. These can occur at time scale range from the second, that is interfractional, and to several weeks, that is interfractional. We have no quantitative information on inter and interfractional changes if IGRT is not applied. There is no doubt that the most conformal radiation treatment given today would not be possible without state-of-the-art imaging and image guidance techniques. Left panel shows the actual patient respiratory pattern, and respiratory pattern is sinusoidal motion, but it is not always reproducible. Several treatment centers manually adjusting the gating window when respiratory pattern is buried. But it is questionable it is acceptable or not in clinical point of view. Right image shows the interfractionary positional variation in between first fraction and 12 fractions. At first fraction, tumor position at exhale was within the gating windows, but at the 12th fraction, it was shifted to the upper side of the gating window due to the interfractional variations. Most treatment centers use the external surrogate system to monitor patient surface motion for the gating treatment. It relies on the assumption that the observed external respiratory signal is well correlated within the actual internal tumor position. On right panel, red line is the internal tumor position, and blue line is the patient abdominal surface positions. This image shows the lower correlation cases. That is when external signal shows exploration, but actually tumor located in hell positions. This is not so many cases, but we should consider these situations. To improve the gated treatment accuracy, it requires the directly monitoring of the moving tumor using medical imaging systems. Several types of imaging modalities are now clinically available, but in our hospital, CT and X-ray fluoroscopy systems are installed. For the CT, imaging is performed for all thoracoabdominal cases to generate 4D treatment planning. 4D treatment planning is mandatory to evaluate OAR doses, including time axis, because we optimize the treatment planning parameters to always irradiate the tumor, even though the tumor moves interfractionally, but the treatment beam is not always irradiated to OARs. And for the CT, is also used for the training data to perform the markerless tumor tracking in the treatment room. And X-ray fluoroscopic images is used for the markerless tracking during treatment. And we do not yet install the CBCT or in-room CT for the purpose of the replanning. MR integrated treatment machine is now commercially available. However, when gating treatment began in 2015, the only medical imaging device to meet our specification, that is spatial temporal resolution, was the X-ray fluoroscopy systems. So we installed a pair of the X-ray fluoroscopic system here and here. And the imaging system, we use the very young flat panel systems. And the installing angle is plus minus 35 degrees. And SID and SAD is right here. And the image size at the eye center is 20 cm. And due to the installation angles, partial exposure area like this here is overlapped. And our default imaging condition is 100 kV, and the tube current is adjusting for respective patient. Our approach to minimizing imaging dose, we optimize the gating window for each patient. Generally, the gating window is set to 30% duty cycle around exhale, but we try to extend the gating window until OAR dose is past the criteria. Because wide gating window decreases the treatment time, as a result, imaging dose could be also decreased. Treatment beam is on within the gating window, which is defined on the treatment planning. Therefore, when patient respiratory pattern is changed, small gating window cannot irradiate the beam here. But wide gating window prevents these situations. Therefore, OAR doses are less than the tolerance level. The gating can be expanded to cover interfractional small positional changes. Next, our approach is to minimize imaging dose is applied image processing to improve the quality of X-ray fluoroscopic images. But it required real-time image processing. It is hard to integrate the big computation processing. So now we develop the real-time image processing, and it is well balanced in image quality and real-time processings. And so this movie shows real carbon beam treatment movies. And so here, this movie shows the lung treatment cases. And the yellow line shows the target, that is a CTB shape. And this orange or green circle shows the gating window that is defined in the treatment plannings. And both target moves within the gating window, the treatment beam is irradiated. And so in this case, we set the gating window is about 40%. And so in this case, the treatment time is 3 minutes per fraction, and the beam on rate is 45%. And image condition is like this. And in this case, skin dose is about 16 milligram per fractions, including partial overlap regions. And macro tracking accuracy is about 1 millimeters. If this case, we use the external gatings, the gating accuracy is degraded to about 1 centimeters. And from so we now we treated about 200 patients using the macro trackings for 5 years, and the gating beam on performed less than 1 millimeter accuracies, and even though interfraction variations are caused. And imaging dose is in average over all patients is about 20 milligram per field, including partial overlap regions. And so this is, I think, so this is a well balanced tracking accuracy and X-ray dose reactions. And so the gating accuracy is for here. So lung case is internal internal gating accuracy is 0.2 millimeters, and river is a little bit degraded about 1 millimeters. And imaging dose is for lung is 13 milligram per field, and river little bit increase to the 30 milligrams. And so summary, so there is no doubt that the most conformal radiation treatments given today would not be possible without state-of-the-art IGRT. The two major advantages of IGRT is its visualization and quantification of uncertainties caused within the patient and improvement in the treatment workflow. We effectively incorporated marker tracking based on the fluoroscopy into heavy practical therapy, and by utilizing 4D treatment planning, image processing, and machine learning techniques, and so we minimize the imaging dose. Thank you very much.
Thank you very much, Shinichiro, for overviewing the image-guided carbon therapy procedures. So, Colin, we will move on to our discussion part.
Yeah. If you could raise your hand if you have questions and indicate which of the speakers the question's for.
Good afternoon. Thank you very much for your very interesting presentation. So my question is, I'm just wondering if it's possible for the CT to be, the data of the KVCT to be incorporated in the TPS, treatment planning system, so that it can calculate the dose if it's possible.
I can potentially comment on that. There are, it is difficult because KV calculations would require Monte Carlo calculations to be accurate on a 10% or so level in terms of dose. But it is relatively easy to just add the CTDI dose to critical structures. We do that sometimes when we are close to tolerance, and then just say each cone-beam CT taken adds 1.5 centigrade or whatever it is to the critical structure, but not to the target. And unfortunately, and I shouldn't say unfortunately, but the task group 180 of the AAPM just has come out with a report which basically indicates that unless the dose from imaging is of the order of 5% of the dose to the target, these sort of efforts are probably not warranted at this point in time, which basically gives the manufacturers a bit of an easy way out of working on that process. But I do think all the users should encourage the vendors to do exactly what you said.
So very difficult question. So because to improve the and to keep the treatment accuracy, radiotherapy accuracy, so the current KB image is just required doses for the keep the treatment accuracies. And so we every day try to minimize the imaging doses. So however, we did not yet set the criteria, the imaging doses.
Any more questions?
Thank you all for your presentation. I wonder if one of the purposes of the TG116 is to standardize the calculation of those. How is going to work, or how are you dealing with the another geometries of machines as tomotherapy, for example? Because I saw the data and you show only C-arms, linear accelerators.
We will collect data for tomotherapy, but we want to get things sorted out for the standard systems, and then once we have done that, then we can move on to consider other things and how we should modify. I mean, for instance, the slab phantoms that we've been using, they're not really appropriate for doing measurements on head. So in fact, what we're trying at the moment is a more limited number of perhaps 12 slabs. So we have a phantom which doesn't mimic the head in the same way, but has maybe not too dissimilar attenuation properties. And so we might be able to use that as a sort of another standard that we can make comparisons with. I mean, we're looking for ways to enable centers in countries that just don't have the standard equipment to be able to make measurements and allow comparisons to be made between different centers. So, but tomotherapy, eventually, we would look into, and maybe you in Colombia can help us with that.
Maybe a comment as well. In some respect, we are really hoping that tomotherapy can help us out with convincing vendors to include dose distributions, because tomotherapy is using a megavoltage beam, and there a much simpler dose calculation algorithm probably would be sufficient to provide a reasonable dose distribution which could be added to the treatment planning process. The same would apply for the older Siemens machines which use MV cone beam or some other portal imaging processes where Varian has now released a 2.5 MeV beam for imaging. So there is actually a lot of hope that tomotherapy will help us out.
Any more questions?
Maybe then I can make probably another comment about the manufacturers and inclusion of imaging dose. There is currently a trend towards towards hypofractionation, which reduces the number of imaging protocols. So I think the areas where we need to focus on in terms of including dose in imaging would be head and neck treatments or pediatric treatments, particularly where hypofractionation is not likely to play a very important role. So I think that there is some rationale and to get clinicians on site to ask for that as well.
Well, I have a question for you, me. Well, as we are discussing, the optimization procedure is very critical when looking at imaging in radiotherapy. So when you are wrapping up and the analyze the posters, do you find some trends or some efforts in order to achieve optimization procedure in the imaging of radiotherapy? Do you find some papers that handle optimization procedure for imaging in radiotherapy, or do you find something, some posters very interesting regarding the optimization?
Every post is good, so
Okay.
yeah.
You found that. Yeah, all the posts was so good and interesting. Okay, thanks.
I think as no more questions, we're getting to the end of the day. Everybody's ready to go home. I think we'll call it a day. And thank you all for coming. And thank you to all the speakers for quite an interesting session, I think.